Welcome to the Rise for Equity podcast. In this series, we'll be talking to leading physicians, scientists, and innovators about what it's going to take to transform healthcare for a more just, more equitable future. I'm Nicole Nfonoyim-Hara, your host on the Rise for Equity podcast, and today I'm joined by Dr. John Halamka and Dr. Sonya Makhni. Together, we're delving into the equity implications of AI in healthcare and the work of Dr. Halamka and Dr. Makhni in advancing just and equitable solutions to AI as it revolutionizes the healthcare landscape. Welcome, both of you, to the podcast.
Well, thanks so much for having us.
So AI definitely seems to be having quite a moment in our popular culture, in our public debate right now. And frankly, some of those conversations can range from the very utopian to the downright apocalyptic. So I think I would love for us to just open up our discussion on AI in healthcare by having you share how you define AI in the context of medicine and healthcare, and what is the difference actually between artificial intelligence and augmented intelligence, though they have the same acronym there.
Artificial intelligence is nothing more than the simulation of human thought process. Really, that's it. And this has been an overnight revolution, 50 years in the making, right? As we'll talk about on this podcast, this has been going on for decades, even though it may be more popular today than ever. But it's math, not magic. And all we're doing is simulating the way we think and converse.
I agree. I'd like to think about how science and analysis evolved. So, centuries and millennia ago, our practices to scientific endeavors were very different, random, highly variable practices. And then we have, in modern times, statistical analyses, and that helps augment our insights and helps arm us with more quantitative analyses that can help us think through different problems in a different way. I like to think of artificial intelligence as somewhat similar. Here we are at a new era where, just like Dr. Halamka mentioned, it's math, it's insights, and how can we use those insights to advance our thinking and practices, I think, is the focus of today.
Wonderful. Thank you both. Dr. Halamka, you said, this is a revolution 50 years in the making, and I'd love to hear from both of you about when did we first start seeing the use of AI in healthcare and outlining some of that history and progression for us.
Well, sure. So, since I was there, you see, this is the great thing. Sonya is the next generation, the person who will replace me. So from 1950 to 1956, there was a golden era of AI. It initially started with a conference at Dartmouth that was organized by a couple of folks like Alan Turing and John McCarthy. I was John McCarthy's student. And they hypothesized that someday you would be able, through programming, to replicate human communication. One of the people who attended that conference, a guy named Joe Weizenbaum, wrote something called ELIZA, which was to simulate a human therapy session. And interestingly enough, in my career, I've actually worked on ELIZA and augmenting ELIZA. So again, think of this as a phenomenon. 1950 to the present, going through an era when the computer was as powerful as today's toaster.
Thank you for sharing that. And Dr. Makhni, your thoughts just in terms of the future, what that history means for the next generation.
I think, for the future, and I think we'll cover a lot of these topics today, is how do we leverage these insights and these new ways of thinking to actually transform our delivery of healthcare for the better? So how do we make sure that we understand all the benefits and limitations of what we're delivering, like we mentioned earlier, the advanced math, and how do we actually harness that in a way that's clinically meaningful? I think those are two very different things. There's one thing to analyze troves of data, and there's another component to actually making those insights useful and responsibly delivered. So I think now we're in the era where we have the technology with the abilities, we have the mathematical capabilities, met with the fact that we now have unprecedented levels of computing power. But what to do with that information in a meaningful way is actually the next challenge, because as we'll discuss, the healthcare system is complex. We aren't building a trinket. We are caring for patients' lives. And I think what we do with that mathematical information is actually, it's not always as simple to translate that into clinical benefits.
Well, thank you for sharing that. I think there are certain ways in which the healthcare system, I mean, the healthcare system is incredibly vast. The topic of AI, its applications are very vast. Can you think about how, I guess, some ways in which we could think about some concrete everyday ways in which AI is showing up in our healthcare system today?
Sure. I think what's really interesting is that I think we are using AI more than we realize. Simultaneously, we're not using AI as much as we would like. So there's some very interesting algorithms out there that really augment the way clinicians are practicing medicine already. Radiology AI is a great example where there are wonderfully validated algorithms that really help clinicians in terms of triaging severe diagnoses early, or helping them pick up on diagnoses that may not have seen, with their naked eye. And I think those are already coming into play. I think we also have a ways to go. I am a hospitalist, and I think it's interesting because I know when I look at my dashboard, my patient dashboard, I can see how certain algorithms are helping me decide and understand the clinical severity of a patient, the clinical acuity, their likelihood of readmission. But I think there's room for more. I find myself often wondering and wanting, extra additional insights. And I think we're approaching that level where artificial intelligence solutions will permeate more readily in practice.
Well, and maybe add to that a personal example. So I have a supraventricular tachycardia, which means my heart rate goes from 50 to 170, sometimes irritating, not life-threatening. Now, the problem with capturing any heart arrhythmia, they don't happen very often. And so it's not as if you can go to a doctor's office and say, I'll be here for 20 minutes and we'll capture that arrhythmia. Whereas AI can look at what could be hours and hours of rhythm strips and say, oh, yes, at 9:20 in the morning, you had an episode. Mayo has created a whole series of cardiology-based artificial intelligence algorithms to examine rhythm strips and look for not only disease you have today, but disease you may develop tomorrow. I am the recipient of the use of that AI because that's how my diagnosis was made at Mayo. And the treatment decision, give me 25 cents a day of a calcium channel blocker called diltiazem, cured me. And yet, this condition I've had for decades was never diagnosed properly before AI.
Yeah, that's an excellent example. Thank you for sharing your insights, both of you. AI is becoming so much more embedded in the delivery of care in our lives. And I think there are all of these benefits, and we're going to continue to talk about these benefits. And then also the challenges that you alluded to, Dr. Makhni, around certain ideas around the responsibility we have now with the AI tools. And those are ethical challenges for sure, logistical challenges. And I want us, I guess, to start us talking a little bit about some of those challenges here. In terms of those challenges, how would you categorize those challenges, just to kick us off, and then maybe we can dig a little bit more deeply into each of those?
Sure. Yeah, I like to think of this in sort of some broad categories. I think there's some general categories to, or general pieces that are slowing our adoption of AI solutions. And I think I like to think of those in a few buckets. So one, it's a data issue. How do we get data of great depth, breadth, and spread and diversity? And how can we securely access that data? How do we have the tooling to innovate and create algorithms that are meaningful to care? How do we validate those algorithms to ensure that they're generalizable and that we understand their biases? And then how do we deploy them at the point of care so that we don't create more biases and we actually create positive outcomes? And I think throughout that process, we also have to think about the AI development lifecycle. So when we're creating these algorithms, bias and other challenges to equity can creep in at all these different phases. And the AI development lifecycle itself, you're designing an algorithm, you're procuring the data, you're developing the model, you're testing it, and then, like I said, you're deploying it. So when you mentioned, how do you think about this in a sort of structured way? I like to think about those phases and understand what kinds of challenges to security and privacy and bias can creep in each of those levels.
Thank you. Dr. Halamka?
Well, and so I always describe AI as a continuum from ideation. I think I'd like to implement this new technology, to gathering the data, which is what Sonya described, to developing a model, and then testing the model. Now, just because you developed it in Minnesota doesn't mean it's going to work in Florida, right? That is, the populations are going to be different, the food they eat, the lifestyle they lead, right? And so you can never assume that even with an extraordinary amount of data, that you're going to develop an algorithm that is going to be fair, appropriate, valid, effective, and safe. Every algorithm will be biased because of the way that it is trained. You have to pick some group. And so recently, I was asked, well, I see you've looked at your data from a social determinants of health perspective. So you have those that are rural and urban. You have those that are educated and those with less education. You have those with income and those with less income. But have you really taken into account the demographics of every patient that Mayo might treat in the world? The answer is no. Which is why we have to then partner with organizations around the world to be our co-developers and testers, the validators of these algorithms, to say, yes, it does work in Australia. Yes, it does work in Spain. Oh, it doesn't work so well in Portugal. And so we have to redo it, tune it, change it, etc. And it will not be a one and done kind of thing. Here's a challenge. You may remember back in, say, March 2020, there was this thing that happened to us all where we suddenly went from offices to Zoom. Now, I would argue things like that, societal, cultural shifts, a pandemic, wildly change how algorithms are developed and should be used, because we all started behaving differently. And I'm not suggesting to anyone listening to this podcast that this is true, but I read in the New York Times yesterday that alcohol consumption during the pandemic went up by over 20%. And in those over 65, went up 50%. Okay, well, if there's a data change, alcohol consumption goes way up. You can imagine any algorithm we trained pre-pandemic may not work so well post-pandemic because the underlying behavior and data changed, which is why, as Sonya was getting at, gather your data, test your model, retest your model, monitor your model. It's a process, not a project.
Thank you both for outlining that. I think from sort of the layman's view, and I'm certainly in that position, it's so helpful to have that view of sort of the life cycle. I think often we think about data if we're not sort of dealing with it. I mean, we're all dealing with data at some level, but if we're, not in the spaces that you're in, I think sometimes data, it's like, oh, it's sort of this neutral thing out there in the universe. And the idea that it's sort of being shaped by behaviors and social determinants, social factors, real lives, right? All of those things that you've been outlining for us is, I think, really important. And of course, gets us to continue in this conversation around that data, because it's not neutral, because it's changing, because it's impacted by all these social factors. Can you talk to us a little bit about how faulty data can impact patients and patient outcomes?
The topic of data is complex just for the reasons you mentioned. We are essentially, if you think about clinicians, first of all, when we make a decision, we look at structured data elements, we look at telemetry, we look at imaging, we use all that information to come up, as well as our intuition. And we use that information to come up with a diagnosis and treatment plan. With algorithms, we're essentially feeding, algorithms a subset of information, a subset of that picture, and expecting or hoping or wishing for an algorithm to create an insight or a hypothesis that is equal or better to what we would do as clinicians. Now, for the reasons you mentioned, the data, it's only as good as the data we provided. And data itself can be biased. So we can incompletely collect information, or data can represent biases in the underlying population. So certain conditions are systematically underdiagnosed in specific subgroups. So as you can imagine, when we're trying to say, let's say, take a condition like depression, and we use that in our algorithm, well, if society and our practices misdiagnose this condition for certain subgroups, we can understand how that will filter in forward through the model development, deployment, and monitoring, also with biases. So when we think about, to your question of how do we think about data, we like to think about mitigating those risks by having data that represents diverse populations in large enough volumes with enough spread and depth to kind of cover our bases. But at the end of the day, it's not perfect. So, oftentimes what we need to do and implement is actually the analysis downstream to understand, okay, how are these subgroups being disproportionately affected? Because what happens is an algorithmic bias at the beginning can skew data of an algorithm's performance. And that skew of performance can lead to health inequities. So the question becomes, okay, how do we use mathematical methods to reveal our blind spots? So as Dr. Halamka said, algorithms will be biased. It doesn't mean that they're wrong and unusable. What it means is that we need to illuminate those biases. And we can do so in mathematical methods by statistically measuring performance differences across subgroups. These subgroups could differ based off of gender, race, BMI, anything. And we also needed to take a qualitative approach. And that approach happens throughout the data development lifecycle, where we think about how our variables that we choose, how our outcome variables that we choose, how our methods might reflect biases that we're not fully aware of. And so in this way, from a qualitative and quantitative approach, we can perhaps get closer to where we need to be, which is showing how an algorithm might perform well and where it might not perform well, so we can be smarter on how we use those algorithms. And we can actually monitor for safety and health inequity problems that might arise downstream.
Dr. Halamka, any thoughts on that?
Last year, a wonderful journalist, Casey Ross at STAT, wrote an article which said AI in healthcare has a credibility problem. And to Sonya's point, why is it a problem? Well, if you don't know how it was developed, what patients were used to train it, how are you going to believe it's going to help you? So in Casey's words, we need transparency, which is a so-called data card and model card. How was the algorithm developed? And how, when it's tested, does it work on patients like me? And then we need a sense of reliability and consistency. We need to monitor it over time. I mean, to my point, the data shifts, societal needs shift. And so if you could say, here is everything about this algorithm and its performance, and here is its history of how it's helped people like you, and it has generally helped people get better, you say, okay, well, that sounds credible.
No, thank you for including that. My next question was actually going to be about this. There is a history of mistrust that we know, certainly in medicine and science and in healthcare, and that mistrust is widespread among certain historically marginalized groups. And we do know that AI has certainly exacerbated that in a lot of different ways. And you mentioned earlier, Dr. Halamka, partnership, right? And what that looks like in order to have different data sets, and have, something might work here, but it might not work there. And what does, I guess, partnership and community engagement look like in this field, in this realm?
I travel about 500,000 miles a year. I'll be in 21 countries this year. And what you find is societies are hungry for this notion of safety and efficacy around AI. In the European Union, they have the EU AI law. Germany just passed a new AI law. So everybody is saying, how do we do this right? And what they're saying is, wow, we can't solve it just at a country level. We have to solve it as a global community. And so what you're finding is collaboration and partnership and coalition building like I've never seen before. And hence this Coalition for Health AI that Sonya and I are involved in. It's truly bringing together now 2,200 organizations globally to figure out some of these problems together.
Dr. Makhni, and please share a little bit more about the work of the Coalition for Health AI.
Before I hand it back to John, just to add to that as well, what's really interesting too is now we're seeing what has been a previously fragmented ecosystem where maybe our technical innovators sit on one side, our healthcare providers and clinicians sit on another, and our entities that hold the data sit elsewhere. That ecosystem has previously been quite fragmented. And you can imagine what happens when these sides aren't talking. You develop technology for the sake of technology without the clinical context, or you're not able to innovate, even though, a clinician might have deep domain expertise. They might not have the bandwidth or resources to create meaningful technology. And of course, the data, data exist in silos. And so we create a solution on a siloed piece of data or a siloed segment of data might not translate to a generalizable algorithm. So what we're also seeing is coming together, not only of these separate entities, as Dr. Halamka mentioned, but of all the players in the chain that can contribute to meaningful innovation. And I think this is going to lead to amazing results as we continue to hone these relationships, because this is the true collaboration that healthcare needs in order to make sustainable innovation that's scalable, but also meaningful.
All right, so the Coalition for Health AI was founded with the notion that how do we define fairness? How do we define bias? How do we define what is appropriate or effective? How do we even define safety? And so its notion is, working as a community, we can develop the guardrails and the guidelines for every society to measure the performance of these algorithms. And as we've been talking about, develop the best practices for managing them over a life cycle. As Sonya said, it's important to realize this. If every algorithm is biased, that doesn't mean we should use no algorithms. It means that we should use the algorithm in the right context, where it is going to provide benefit and minimize harm. And really, the Coalition for Health AI is about defining that kind of workflow. The vision is we'll end up with a nationwide network of AI assurance laboratories that are testing these things and publishing openly in a nationwide registry how they perform and where their biases are to be found, how to mitigate those biases. You're going to see an interesting interplay between industry, academia, and government. And sometimes I describe a perfect storm of innovation when all three of those entities come together on a single urgent mission. And that's what's happened in AI. So Coalition for Health AI includes the White House, the FDA. It includes a variety of industry, large and small. It includes academia, large and small. So truly, I describe it as benefit of society, hegemony of none.
Well, that this perfect storm of innovation and the ways in which, that is really necessary. AI is in all parts of our lives, and we're here talking about healthcare particularly, but it's something that's it's part of the ether in a lot of ways now as well, and the importance of having those guidelines and parameters, but also continuing to figure out how to, as Dr. Makhni was talking about, throughout every stage of that life cycle, being able to sort of mitigate what those biases are. I think both of you have said it so clearly and highlighted so much around how algorithms, we can't just throw them out, right? You can't sort of throw the proverbial baby out with the bathwater because it's not working or it's got biases in some way. And to that note, we've spoken a little bit about how AI can reinforce bias and inequality. I'm also interested in the ways that AI itself can prove to be a powerful tool in actually helping to dismantle health disparities. What are your thoughts on that?
So I trained in emergency medicine in the 1980s. Do you know a few things have changed since then? And here's a problem. In the United States, how long does it take an innovation to disseminate throughout the country? 20 years. Well, that means, especially in, say, rural areas, or in federally qualified health centers, critical access hospitals, they may not get the benefit of the latest discoveries and innovation. And therefore, there are going to be disparities of care depending on where you seek that care. The wonderful thing about AI is it captures knowledge and democratizes access to that knowledge. Any doctor anywhere, any patient anywhere can get the benefit of the best knowledge gathered across our entire population. So again, we have to be careful because we need to tune it to a local population. We need to understand its biases and mitigate them. But what excites me the most is the notion that you don't have to go to some rural academic medical center to get the best care. You could get it at home because the algorithm is coming to you instead of you going to a bricks and mortar facility.
Completely agree. And I think this potential to move healthcare from reactive to proactive and to treat patients earlier in their disease process is, I think, is so exciting. And I think to Dr. Halamka's point, once we're able to democratize these insights, we can then raise the bar to the quality of care we deliver. So it's equal parts up to the technology and equal parts up to us to understand how to harness the technology and hold ourselves accountable in terms of, making sure the technology developers and the technology users are ensuring that we are in actuality also pursuing a raised bar of clinical practice. But to be able to diagnose conditions far earlier, to be able to reach patients who have social determinants of health barriers that prevent them from accessing care in a way that maybe you or I might be able to by living near a major health center. I think to be able to do these things is incredibly exciting and I think very doable. And so I think we're reaching that point, and we have hopefully the correct kind of considerations in our dashboard to look out for, such as bias and safety and harm, for example.
As you think about what's on the horizon for AI in healthcare, can you tell us a little bit about the Solution Studio and the work of the Mayo Clinic platform and what it's doing with this new program?
So one of the things I love doing is educating the next generation. And when you find the extraordinary entrepreneurial energy we see in many young people, there's only two things they're lacking. Clinical expertise, they may not be fully trained as experienced clinicians, and access to, as you've heard Sonya describe, large amounts of privacy protected, consented, de-identified data. And so with Solution Studio, the idea is we find the best innovators and then mentor them and bring them into an environment where in an ethical fashion, they're using de-identified data. They don't take it with them. It's never sold, nothing like that, but they're using the de-identified data to tune their products, to refine their products, and then deploy them into workflow so that clinicians have that benefit of that AI innovation right at their fingertips. And I'll tell you, that's hard. It's hard work. And Mayo may be the only organization in the country right now able to take an entrepreneur's energy and enthusiasm and translate it into a deployed patient impacting solution.
Well, I was just going to follow up with that in terms of, is that a model? Do you feel like that is a model that can be replicated? You're saying Mayo is the only one right now.
Well, and the answer is Mayo is charged with not only making its practice better and capturing knowledge, it's charged with global transformation of healthcare. So I mentioned this notion of 21 countries in 2024 and traveling 500,000 miles a year. That's taking our methods and locally empowering organizations around the world to offer similar kinds of services in their demographic. So that is, don't think of this as Mayo as the center, a hub with spokes. Think of it as a peer, empowering others in a global peer-to-peer network, because local empowerment is really important.
Thank you, Dr. Makhni.
And And one of the pieces that's really exciting to Solution Studio goes back to the principles that we've talked about earlier. So in conjunction with TRI, we've helped lay the guardrails of what it means for a solution to be responsibly developed and deployed. These include pieces like privacy and security enhanced, safe, fair, transparent, explainable, useful. Now, operationalizing on these is not trivial. And so what we're doing in Solution Studio is actually just that. We're taking these metrics in a way, and these factors in a way that's never been before operationalized in a proprietary process. So what we deliver to healthcare providers, we feel confident in how that those solutions adhere to principles that Chai and ourselves have laid out as to be important.
Thank you both. I think as I'm hearing you both speak, I think, and you mentioned this, Dr. Halamka, this empowerment piece is really an important part of it. And really, at the end of the day, I would imagine that we want to be able to use AI and its tools to empower sort of at the local level, to empower individual clinicians and to empower patients as well. This is an enormous question, but from your own perspective, given what you know and the work that you're so committed to, what does the future of AI look like in healthcare? If you were sort of be a futurist in this sense.
I've been a physician for 40 years, and I will be honest, and Sonya, welcome your thinking here. In those 40 years, I have found navigation of the U.S. healthcare system to be hard. Who do you see? How do you access them? Is it a specialist? Is it a primary caregiver? What should your journey look like? So what happens is, instead of just having a system where every patient is empowered to have expert advice, patients either wander from doctor to doctor, which takes a very long time and creates delayed diagnosis, which results in typically more serious disease, expense, or even pain. Or they ask and they say, hey, I know my next door neighbor is a physician. Maybe they can help me navigate, right? All of these methods are neither scalable nor a good exemplar of the triple aim, right? We want higher quality and lower costs. And how is it that we can imagine a future where we have an AI doctor in our pocket, so to speak? And this isn't to say we're eliminating doctors, not at all. But to say, what if every patient received at birth an AI tutor and helped them with educational navigation, and an AI doctor that helped them with healthcare navigation? Oh, 1 million people like you with these signs and symptoms in your history went here, and they got a good cure, and they got it rapidly. That's what I hope happens. Call it Google Maps for healthcare, coming soon.
Thank you, Dr. Makhni. Your thoughts?
I agree. When I think of the patients that I treat and what kind of challenges they've experienced to staying healthy or being healthy, I think of a few pieces: access, like Dr. Halamka mentioned, engagement or understanding of their healthcare, resources as well. And I think the aim is to use these solutions and technologies, whether it be the Google Maps of healthcare, or whether it's a more empowered patient. I think the aim is that we upskill not only ourselves as clinicians to have, the ability to, decipher better insights, but to have patients who are more engaged and more involved in their care and more able to participate from where they are in life. So maybe they might not be a patient who wants to engage on an iPad. Maybe they prefer a telephone. So how do we scale these technologies in a way that reaches everyone and everyone equally, so that we don't create larger divides? And I think the methods to do so are very exciting. Like Dr. Halamka mentioned, I think those would be, the ideal state someday. And then everything before that is a journey that we can embark on using our community leaders, using our healthcare providers, and using our colleagues to kind of help arm patients with those tools that will help them have better access and better engagement and understanding with their care.
So we started the conversation, I talked a little bit about some of the public and popular sort of debates and thoughts around AI. ChatGPT is something that's come up quite a bit. Can you talk to us a little bit and help us understand what generative AI is and sort of how to think about the different types of AI in this context?
Well, we started our discussion today by talking about the 50-year history of AI. Now, we should have been a little more precise. That 50-year history is predictive AI. What does that mean? Well, I've seen this pattern a million times before. It's very likely if you as a patient have these signs or symptoms that you may have this disease. That's math. It's probability. It's statistics. Generative AI is different. Generative AI is predicting the next word in a sentence, for example. Large language models do that. If I look at trillions of sentences, what word is likely to come next? Well, here's the challenge. Generative AI gives a different response every time you ask it because it's a set of probabilities. One of these 5 words might be the next word. Okay, let's pick the third one. Well, then what would be the next word? Let's pick the second one. And before you know it, here's a problem. At 10 in the morning, you may get a brilliant answer. And at 10:01, you may get fiction or hallucination. So when we talked about AI needing reliability, consistency, the problem with generative AI is sure, it's useful for many purposes, but it's probably at this stage not reliable and consistent enough to use for any kind of diagnosis or treatment planning or medical decision making. One of the things it can do very well is summarize a conversation. So if after this podcast we said, hey, generative AI, tell us what we talked about. It'll give you 10 bullet points and they'll be fine. It's pretty low risk. It's a pretty high utility. And I think we just need to ask in this next year to two, and I'm not saying 5 to 10 years it won't be better, but the next year to two, where are those high value but lower risk uses of generative AI, understanding it's just predicting words, not really using statistics to make decisions?
And to add to that, when I think about how we use predictive and generative AI, I break them down in just the way Dr. Halamka mentioned. So, predictive AI, it's you analyze data and predict a future event. So it could be a yes or no answer. It could be a numeric value, or of course, more advanced elements. But you're forecasting a future outcome and you're potentially, discerning some sort of a classification. So these types of solutions that use, the more traditional predictive AI, they might be more point solutions. They might be more discrete, but they might be very valuable. And there's still room, very much so, for predictive AI, even though a lot of the talk and focus is on generative AI out there. Generative AI, as Dr. Halamka mentioned, you analyze data, you train a model, and you generate new content. So that content could be speech, it could be an image, it could be code, it could be audio, and it could be text. So you're simulating human-like creativity without actually, necessarily having it or guaranteeing it. So, to Dr. Halamka's point, I think there's very specific use cases that we at Mayo Clinic classify based off of risk that we might feel more comfortable with utilizing generative AI solutions, but others that we might not. So, for example, let's say you have a guideline that's been well established by, in the cardiology societies for how to manage and treat a heart attack. That information has been validated. There's lots of information. And you might imagine that a generative AI solution could probably, if trained on the right data, could probably output a very reasonable plan. Of course, there's still a risk of hallucinations and misinformation, but you might imagine that it might do okay. Now take critical care medicine, where there's a lot more human intuition involved. There's a lot of judgment and not always specific evidence-based practices that are established in the literature or by guidelines. So if you have a generative AI solution or a model that you ask, for help on how to treat a solution in the treat a patient in the ICU, that output might be a bit different. you might not have a lot of concrete data to train that, to feed into that model, just by the nature of the context that we're working in. And I might be more hesitant to trust the output. So as you can see, there's different layers and different levels of risk. So summarization, reducing administrative burdens for clinicians, helping patients understand their care. That might be where that likely is where we will put most of our focus right now. And asking a model to devise a complex treatment plan for a critically ill patient with multiple comorbidities and rare conditions, that might be something for a later date. But I think that there's definitely pieces of the pie that we can start to kind of to nibble off right now, and then leave the rest as we get more advanced with our understanding of the potentials and the risks of generative AI models.
No, thank you both for that clarity and those distinctions. And as we're closing today, do you have any final thoughts around this topic and things that you'd just like to share as we're closing here?
So, as you asked, and we didn't precisely answer, AI could mean artificial intelligence, or it could mean augmented intelligence. AI, it's not going to replace your doctor. That's why I like to use the term augmented. It's making humans better by offering them some additional knowledge, not suggesting it's going to replace them. How about this? If an AI could replace your doctor, an AI should replace your doctor, right? We go to clinicians for empathy, for listening, for respect, to calm anxiety. We don't go to doctors just for machine-like decision-making. So that's why let us hope the future is every clinician we see will offer us the benefits of humanity, and they will be augmented with the math and statistics, incorporating the experiences of millions of patients like you. And that's what you can hope for: better, higher quality care, not more machines caring for you instead.
I could not have said that better myself. And I would leave with just a parting advice. I think we're seeing a lot of hype and excitement with AI and generative AI, and I think it's founded. I think there's a lot of really amazing advancements to come that can transform our healthcare system and hopefully solve a lot of the problems that we've been needing to solve. But my advice would be patience. I think what's really important, and maybe the most important, is that we do so responsibly. So rather than jumping into the newest widget that promises to deliver an outcome, maybe we take a breath and we stop and we just ensure that what we're delivering adheres to those principles that we know are so important, as outlined by Chai, and that we understand, how do we need to monitor this solution? How do we need to track it to make sure that all equity concerns and safety concerns are being addressed, or at least that we're aware of them? And I think once we do this a little bit more deliberately, we'll get to our end place. We'll get there. It's a matter of time. So much has changed over even a year and a half that, I am not worried that we won't see great advancements in, the areas of technology and AI and medicine. What I think is maybe more of our focus is, for now, let's do so ethically, responsibly, and in a way that gives us an ability to ensure what we're delivering is truly beneficial and truly not harmful.
Thank you both for joining us today, and I think for leaving us with a really empowering vision of what is on the horizon. You've outlined, both of you and Dr. Makhni, your ending statements here, I think really reiterated this sense of sort of respecting the cycle, right? And the patience that's going to be needed, and taking those steps. I think, again, going back to what Dr. Halamka opened up with, this idea of, it seems so revolutionary, it seems overnight today, but there is a history, and that continues, that process continues. You've both given us such salient perspectives on AI in healthcare, its opportunities, its very real challenges. But in sharing those challenges, you've also outlined ways in which new and innovative programs, collaborations, guidelines in the field are paving a way for a future where AI can assist in not only mitigating risk and barriers, but dismantling those barriers and advancing things like equity across the healthcare landscape. And we so appreciate your leadership, continued leadership in this important and urgent work, and all of the story that you've shared with us about what it's going to take to move us forward. So thank you.
Thanks so much. What a great discussion today.
Thank you so much for having us.
And that's all for today's episode of the Rise for Equity podcast by Mayo Clinic. I'm your host, Nicole Nfonoyim-Hara, and we hope you'll join us for our next episode. We'll see you then.